Okay, I'd like to begin by acknowledging the traditional owners and custodians of the land on which we meet, the Wurundjeri people of the Kulin Nation. I pay my respects to their elders past and present. It's really hard giving an introduction to Samar that will do her justice. She's an infectious diseases physician, and she came to me and she said she wanted to do a PhD to obviously learn about research so she could apply it to the clinic. And I really threw her into the deep end because I gave her a couple of tasks. One was to set up a model of tuberculosis, so an animal model of tuberculosis, which is pretty tricky. Only two labs in Australia have been able to do that to some degree of success. And the second was even harder, which was I said, I want you to identify a therapeutic that we would be able to progress for tuberculosis, and no one's done that for the past 30-odd decades. So they were pretty hard tasks. But Samar wasn't daunted by it. She took it on. She worked incredibly hard over the years with significant challenges. Number one, she had me as a supervisor. Two, you had to work in the PC3, which is not an easy environment to work in. And you have to be pretty brave because you're working with a set of pathogens which are reasonably tricky pathogens to work with. But she achieved some tremendous goals, and she'll obviously highlight those today. The attributes that I love about Samar, one, she's a scientific sieve. So you give her ideas, and she's got lots of ideas of her own, but she'll sort of decide what's clinically relevant, what's physiologically relevant, and she's always correct. And so she'll keep what is, and what is not, she'll just toss away. And she's always really, really good in that respect. The other attribute I love about her is that she's the repository for all gastronomy knowledge. So she knows every single restaurant in Australia, which one's good and which one's bad. And her drawers are full of amazing food stuff. So you'll often see me around Samar's desk. In her presence, we're talking about science, and in her absence, I'm pilfering some of her food. So Samar, I'm incredibly proud of the work that you've generated, the really hard work that you've done. And she's incredibly modest, so I'm sure she's only going to show you a fraction of the stuff that she's done, but she's done some tremendous work in the lab.
Thank you, Mark, for that introduction. It's undeserved, really. So, as my title suggests, firstly, excuse my voice. I'm sorry, it's cold this time to itself very badly. But as my title suggests, the focus of my PhD has been on tuberculosis. Now, tuberculosis is a serious and deadly condition. Most commonly causes a pneumonic process that results in cavitation of the lung and leading to coughing up blood or hemoptysis, made famous by movies such as Moulin Rouge and Les Miserables. But tuberculosis can affect really any organ in the body. It can affect lymph nodes, most commonly in children it does so. It can affect the gut, it can affect the spine and can lead to paralysis. It can affect the eyes, leading to blindness, and has other immunological manifestations, including skin manifestations. And ultimately, if left untreated, leads to cachexia and death, and what's known commonly as the consumption, and there's a reason why TB is known as such. Tuberculosis is the fifth biggest killer of all causes of death, and the second infectious killer. Unfortunately, it doesn't have much awareness, especially in places such as Australia, nor does it get enough funding. If you ask people about big epidemics of the world, people will be able to name the Spanish flu, the bubonic plague, but really very little people know that tuberculosis is actually the biggest hidden epidemic the world has ever seen. In the last 200 years, it's killed over 1 billion people, and it really trumps all of these other epidemics. In 2014 alone, 9.6 million people were infected with tuberculosis. The majority occur really not too far from us in the South Asia and Pacific areas and Africa. And in that year alone, it resulted in 1.5 million deaths. We don't tend to think much of tuberculosis in Australia, but we see a fair share of it. I looked up the data last night. In the last month in Victoria alone, 30 cases or so were notified of tuberculosis. And in Australia, in this year to date, there's about 700 notifications that have occurred. In Monash, where I work, we see about 120 cases a year of tuberculosis. It's not negligible. Tuberculosis, the disease, is caused by Mycobacterium tuberculosis, the organism. This was first identified by Robert Koch, who went on to win Nobel Peace Prize. It's an obligate intracellular organism that survives best in oxygenated areas, such as the lung, but it's quite capable also living outside the cell in hypoxic regions as well. It's a very slow organism, divides every 15 to 20 hours, and when you compare it to E. coli that divides every 20 minutes, you can imagine how slow some of these experiments can be. It's an organism that has coexisted with humans for more than 70,000 years, with recent phylogenetic studies essentially taking it back as far as linking it with the mummy DNA from Egyptian times. And it's sort of traversed the world with humans. And humans are its main reservoir. There are some strains that infect animals, including bovis, which infect cows, and that's the strain we use for an attenuated vaccine. As stated, there are multiple strains, all that have they have various immunogenicity and various clinical phenotypes as well. The common strain that's used in the laboratory is the H37RV, and that's the one we use in our model. Now, having survived with humans for more than 70 years, really, points to the fact that tuberculosis is a complex organism that causes complex problems and has a complex solution. In 1993, tuberculosis was declared a World Health Organization. And don't get me wrong, we've made some great gains. Death has been reduced, incidence of new tuberculosis has been reduced, but it's plateaued, it hasn't gone further. And so the World Health Organization has set up some new targets, including reduction of death by 90% by 2030. Now, to reach these goals, there are a number of important steps that need to be achieved. We need to improve diagnosis. We need to reduce the rate of reactivation. Both of these really are important and essential to reduce transmission of the bacterium. But also, we need to improve treatment, as well as, the ultimate would be an effective vaccine. In my PhD, I look at both looking to reduce reactivation as well as improve treatment. However, for the talk today, I'm only going to be talking to you about looking at my work at improved treatments. So our current therapy today includes a regimen of multiple drugs, including 4 drugs, isoniazid and rifampicin being the mainstay. And these drugs are relatively recent drugs. Rifampicin was only discovered in the 1960s. We treat for 2 months with these combination before dropping to 2 drugs. All of these come with a high pill burden. They're lengthy courses. The minimum course we would use would be 6 months worth of therapy, and these drugs can be toxic. In fact, we give a vitamin to try and reduce the toxicities of isoniazid in reducing peripheral neuropathy. And not to mention, there are growing issues with tuberculosis, including multi-resistant drug tuberculosis and extremely drug-resistant tuberculosis. Most of the cases that occur of multi-resistant drug TB occur in setting of people who've been previously treated. And this suggests that treatments are really not the best, whether that's because there's developing resistance on treatment or whether it's because people become non-compliant. You give drugs, lengthy courses, to people who then become quite well and are less reluctant to take medication. Treatment of these is even more complicated. You've got 5 different drugs that you need to add, including injectables, which predispose these patients to requiring hospitalization. Drugs that have been put on the shelf because they're toxic drugs, they're terrible drugs, yet we're taking them off the shelf to try and use in these patients. New drugs that are taken out of clinical trials and used even at very, very early phases because we have no options. These regimens have come with a higher pill burden. They're much lengthier courses of up to 2 years. They're much more toxic and are much more costly. The whole focus has so far of treatment has been on the mycobacterium itself. And really, I think it's about time maybe we start thinking, not targeting the mycobacteria, but maybe the host. So the host mycobacteria interaction is quite complicated, and I don't have time to go through it completely. But looking at, in terms of the immune system, the bacteria is capable of producing multiple virulence factors. Now, it gets inhaled in little droplets of the size of about 5 microns, and because of the size of these droplets, they can linger on, and people breathe them in, and they go into very deep into the airway. They infect alveolar macrophages. In the mouse model that we use, we put mice in these little baskets into this inhalation exposure chamber that we then put the nebulizer in a little the inoculum in a little nebulizer that nebulizes the inoculum into droplets that the mice then breathe in. Now, tuberculosis produces virulence factors that inhibit the recognition of dendritic cells, allowing it to grow before dendrites then are able to recognize it. Dendritic cells are only detected in lymph nodes by about day 9 of infection, where they then activate T cell activation and allow migration. And the biggest T helper subsets involved in tuberculosis is Th1. Then they migrate back into the lung, where they they stimulate macrophages, allowing inhibition of mycobacterial growth and the formation of a granuloma, which is very important in maintaining control of TB. Now, mice don't actually get granulomas, and black 6 mice, which is what we use in our model, basically develop infection that peaks by about day 21, and then there's control enough that they dip slightly, but then they continue on and can live with tuberculosis for quite a long time before they subsequently succumb to burden. Now, one of the biggest players in immunity to tuberculosis is TNF, and we know so based on human experiments where anti-TNF therapy given to people with rheumatological conditions is detrimental to control of TB. These patients get reactivation of tuberculosis. Mice who are missing TNF are increasingly susceptible to TB as well. Now, reason of how TNF works is not fully understood. There are multiple theories and multiple reasons to why we think it works. It's believed to induce chemokine expression, which allows recruitment of cells that then maintain the granuloma. It's obviously important in simulation of the Th1 axis, which we know, again, based on human experiments, natural experiments, where patients deficient in any aspect of these axes are prone to getting mycobacteria. Cytokine production and adaptive immunity, as well as induction of reactive oxygen species and nitrogen oxide synthetase, which are important in bactericidal activity against tuberculosis. At the same time as being important, TNF works as a double-edged sword. Without the TNF, there's not the inflammation, the disease that ensues, and the actual pathogenesis results as a result of the TNF. Now, we also know that TNF is important in induction of apoptosis. And the question is, how important is apoptosis in immunity against tuberculosis? So I don't mean to, I'm going to keep apoptosis very simple. And I'm sorry for this audience that knows so much about it. But just for the sake of those that don't know, apoptosis comprises of 2 pathways. First, the intrinsic pathway, which occurs in a setting of cells being exposed to cell stresses that then lead to BH3-only protein inhibiting the interaction between BCL2 cell survival proteins from Bax and BAC, allowing them to then permeabilize the outer membrane of the mitochondria, releasing APAF1, which binds to caspase-8, forming the apoptosome, which then leads to eventual execution of caspase activation. At the same time, Smac-mimetic is released, and this inhibits the inhibitors of apoptosis, which allow this process to occur. The extrinsic pathway occurs in the setting of TNF family death receptor ligands, including TNF binding to its receptor, allowing trimerization and recruitment of caspase-8 and PAD, leading to activation of DISC and active caspase 8, leading to this process, but at the same time binding and cleaving BID, which then allows Smac-mimetic to be released, inhibiting the inhibitors of apoptosis and allowing this to occur. The literature on tuberculosis and on cell death in tuberculosis is quite varied and very controversial. Some suggest that apoptosis is inhibited, some suggest that apoptosis is quite prominent. And I think the differences basically reflect general data when it comes to tuberculosis. Most of the work is in vitro work, using different cell lines, MTB strains, various multiplicity of infection and time points. But what is known about tuberculosis and cell death is that the virulent strain of tuberculosis induces necrosis. What's been shown is that this is as a way to leach out of the mycobacteria, then allowing other macrophages to come in, mop it up, and that process of propagation to continue. The avirulent strain has been shown to actually induce apoptosis, allowing uptake of these apoptotic bodies by dendritic cells, cross-presentation, and improved adaptive immunity. The way in which TB is proposed to inhibit apoptosis is varied. It's thought to inhibit it via virulence factors, and some factors have been shown to be important via knock-in and knock-out studies. Downregulation of FAS and procaspase 8, although again the literature here is also varied in that the converse is shown in PBMCs that have been isolated from patients with tuberculosis. Interference with TNF and TNF signalling, increased expression of MCL1, as well as interference with the apoptotic envelope via the prostaglandin E2 membrane repair. So our question was really quite simple. Does induction of apoptosis specifically as a way of killing macrophages induce improved clearance of the infection? So my aim of the PhD were to use BH3-only proteins in mimetics and Smac-mimetics to promote clearance of acute apoptosis by promoting apoptosis. I also looked at not just an acute model but also a latent model, but I won't be talking to you about that today. Instead, I'm only going to also be talking about my third aim, which is looking at apoptotic proteins in tuberculosis. So firstly, looking at BH3 mimetics. BH3 mimetics work to inhibit this interaction here, as discussed earlier. The two drugs that I looked at were ABT263 and A1331852. This drug is a potent inhibitor of BCL-XL, BCL2, and BCL-W, whereas this drug is BCL-XL specific. Now, these drugs have been used, been looked at in malignancies. ABT263 has been looked at even in small cell lung cancers, and so the concern about penetration into the lung, which is something I'd be concerned about, wasn't really there. So, but before I moved on, I wanted to see what the expression of these proteins are in an infected system. And so, using monocyte-derived human macrophages, I infected them with various MOIs and harvested them at various times. And what I found was that BCL2 increases with infection, BCL-XL decreases with time compared to uninfected. MCL1 perhaps shows the most significant increase with infection. So moving on to an in vivo system, I used ABT263 in infected mice. Now, we take some mice at day one to see what degree of infection, how much we've given them. The mice will generally, regardless of what you give them, they'll reach an equilibrium by about day 28 of about 1 million CFUs per lung. And it was at that point that it started treatment. Now, when using this drug, there was perhaps a trend that maybe things got a little bit worse with the drug early on, but at later time points, there was really no difference. Whereas at later time points, there seemed to be a significant reduction in splenic burden with this drug. Now, to try and simulate a deficiency model, I used this drug early on prior to infection. What I found there was that there was actually worsening in CFU. No change in spleen burden. And the speculation here is that ABT263 is non-specific, inhibits multiple BCL2 proteins. And so the question is whether we were inducing death of more than just macrophages, which is what we'd hoped to do, and whether these cells we know are important in maintaining control. So moved on to use A1331852, which is a little bit more narrow, working on BCL-XL, sorry. And I basically found that increase was reversed, and there was really no difference at all. Nor was there any difference when I looked at the acute infection model and using it as a form of treatment. No difference in both lung and splenic burdens. Now, using a BCL-XL deficient model specific in the myelocytic and monocytic, and granulocytic lines, I found no difference between controls and deficient mice. However, moving on to MCL1 knockout using head mice that I obtained from Marco Harrell's laboratory, found that, again, there was no difference at all in lung burden. There was a significant reduction in splenic burden. Looking at cytokine profile, I'll just mention here that the 4 cytokines I look for in my model, TNF, which I've shown you is important. IL-6, I use more of a marker of inflammation. Interferon gamma, again, because of the importance of a Th1 axis, but also IL-1 beta, because it's been shown in studies it's potentially important in induction of microbial peptides, particularly cathelicidin, which is important in killing of TB. What was intriguing, however, even though I found no difference, was this finding on histology. Now, this looks very much like a granuloma-like lesion, which is not something I see in the black 6 mice in any, multiple mice that I've culled and taken. We don't really see it, whereas this is quite clear. Now, the granuloma itself is a hallmark of TB infection in humans. It's essential, and it's thought to be a dynamic entity that works to sequester and limit growth of tuberculosis. But it may also potentially be a survival environment for the actual organism itself. And it's composed. And it's composed of macrophages that take on special cytoplasmic organelles that are important in the killing of tuberculosis. So looking closely, you could see that the 2 lesions are quite different. There's this amorphous pink material within, surrounded by lymphocytes as well as macrophages, compared to this, which was an aggregate lymphocytic infiltration. So looking at to see what monocytes are doing in the lungs of MCL1 knockouts, I found no difference at all in the monocyte, no significant difference in the monocyte, in the lung, I'm sorry. But there was a significant difference in splenic monocyte counts. Looking at caspase-3, what I've got here, this is immunohistochemical slides looking at caspase-3 staining. And you can see that there's significant, there's an increased amount within this granulomatous-like lesion in MCL hets compared to black 6 mice. Now, in order to quantitate this, this is a computer-generated image with the help of Lockheed imaging. Essentially, what he's done is put a program together to try and quantitate the positive staining areas. And when I look, there's a difference, although due really to the small number of mice that I had, there's no significant difference. And I'm repeating this, just breeding hopefully some mice soon to try and get to delineate this a little bit better. So in summary of this first part, I hope to have shown you that MCL1 expression is increased and might contribute to actual, to deficiency of MCL1 might contribute to the formation of granuloma, allowing for, improved control and reduction of spread, and that there's a significant increased amount of apoptosis within these granulomas. BCL2 expression is slightly increased, but in vivo, the effect of inhibition really depends on the timing of the inhibition, with early inhibition being detrimental, but later inhibition may potentially allow for control and splenic burden. I'm working to again, immunophenotype this a little bit better and clarify this a little bit better. Meanwhile, BCL-XL really had no effect at all. Based on this, I think BH3 mimetics targeting BCL-XL and BCL2 are probably not likely to be useful, but I am waiting on MCL1 inhibitors to see how they pan out as well. So moving on to Smac-mimetics. So Smac-mimetics work to antagonize the inhibitors of apoptosis. I specifically looked at birinapant, which is a bivalent Smac-mimetic, with CIP1 being the principal target. It's in clinical trials in hematological malignancies as well as other malignancies, and overall appears to be relatively well tolerated. Now, in our laboratory, Dr. Greg Ebert has already looked at birinapant in a hepatitis B model where he injected hepatitis B via adenoviral vectors and found that hepatitis B DNA is significantly reduced in birinapant-treated mice, and that the effect is reversed when anti-TNF therapy is used, suggesting that TNF is quite important for the action of birinapant. Before moving on to an in vivo system, I again wanted to see what these proteins do in an infected system. And what I found using human-derived monocyte-derived human macrophages, was that CIP2 is increased compared to uninfected cells, as is CIP1, although with higher MOIs, CIP1 seems to occur. Though I suspect that might be more of an artifact because we see more death with higher MOIs. There's no change in XIP, TNF, or Fas receptor. I also wanted to see the effect of birinapant on infected cells, and so using bone marrow-derived mouse macrophages, I infected cells and treated them with birinapant and various doses of TNF at day 1, and then harvested them at day 2 and looked via flow cytometry at the rate of death. What was striking was a significant difference in death between infected and uninfected cells. Birinapant at higher doses killed uninfected cells, but there was certainly a dose-dependent effect on infected cells. Looking at THP1 cells as means as a model for human macrophages, again I found that infection itself induces death when compared to uninfected cells. However, there wasn't much in terms of birinapant effect, but I suspect these cells are they're quite robust. I plan to keep them going for a little bit longer and see whether the birinapant actually does have an effect. I also wanted to see what happens to CIP expression in the lung and the spleen, 2 organs that I'm interested in when it comes to in vivo work with birinapant. I looked at 2 different vehicles as well as 2 different doses. And what I found that birinapant in DMSO at 30 had the most significant effect in reducing CIP1 by day 1. Spleen, there was a slight reduction, but not much really overall compared to the lung. And certainly the spleen reverses by about day 4 with very little loss there. And by day 4, all of the groups are relatively similar. And by day 7, most have reverted with only a slight reduction. So based on that, I decided to go with 30 micrograms of birinapant and giving it weekly as the first dosing regimen. Now, Tetralogic have previously also shown that that birinapant does antagonize CIP2. However, the effect is short-lived, only of a couple of hours. So looking at an in vivo model, I again started to treat mice by about day 28 and took the first lot of mice after 4 doses of birinapant. What I found was that there was a significant reduction in tuberculosis in the birinapant-treated arm, nowhere near what we'd expect for standard therapy. Nor did we expect it to be the same, given that this specifically targets the organism. But it was clearly significant with a trend in the spleen as well. Before moving on, I wanted to see whether birinapant has a direct effect in killing of the actual organism itself. And so I infected the macrophages again, treated them with biri. Following day, lysed them and washed them, then cultured the lysate, and found that really there was no difference. And so birinapant, any effect it might have, is not directly by affecting the organism. Now, looking at longer time points, I found this significant reduction with birinapant reducing bacterial burden. However, the difference was really no different to whether we gave 4 doses or 12 doses. But the splenic difference was more prominent with reduced burden. Looking at the kinetics, I want to see at what point do we start to see a difference? We start to see a difference after 3 doses of birinapant. Yet again, I'm seeing the difference with time and as time goes on, but it's just not progressing. It causes that same reduction, but doesn't progress. based on looking at histology, this also confirms that we are seeing, and the reduction in burden is true. Now, tuberculosis has mycolic acid in the cell wall, and so makes it resistant to normal gram staining. So Ziehl-Neelsen staining is what's used to identify it. Unfortunately, it doesn't project very well, and really for that reason, given the fact that the organism is so small, you can see little pink organisms there. I've found it hard to actually come up with a way to quantitate these more accurately other than sticking to CFUs. But you can see that just by me drawing arrows, that there's a difference there. So why aren't we seeing a progressive difference with Biri? Is it that we're killing macrophages and we're not, and thus we're reducing TNF signalling? And so taking lungs and looking at lung homogenates, the amount of TNF and other cytokines in there, what I found with interferon and TNF, the actual infection itself, there's a general reduction in level of these cytokines, which is somewhat not surprising given we know that mice do learn and control it to some degree before they then succumb. But there was significantly more reduced levels of TNF with the birinapant treated group. So I wanted to see whether giving TNF actually rescues that effect. And so I treated mice just prior to their dose of Biri with TNF. I found that I'm still seeing that same effect. There's a trend, maybe a little bit more, but really it's not significant. Looking at the mice themselves, they remained quite well despite the fact that I was giving them TNF, and I expected them that they should get a little bit sicker. So really the question is whether I was giving them enough TNF. So I'm hoping to repeat this with a little bit more. In terms of answering the question of whether we're eliminating macrophages and thus the drivers of TNF, I looked at these via two different modalities, histology and flow cytometry. So with flow, I take lungs, I digest them with collagenase and DNase, strain the cells, and then do flow on them. Depending on the time of when I take the mice following the dose of birinapant, I see differences. At day one, there's a slight difference. Again, due to numbers, I think not significant, but there's certainly a trend to reduce monocyte numbers compared to, compared to if I leave them longer, day 2 or day 7, there seems to be a rebound increase. No difference in granulocytes and no difference in splenic numbers either. Looking at histology, again with the help of Lockie, looked to quantitate this. I found no difference. So we were quantitating these infiltrative, lymphocytic infiltrates to see whether there was a difference. Didn't really see much of a difference between the two groups. The other thing I looked at was INOS as a marker, again, of macrophage function. And essentially, I mean, you can macroscopically, looking at these slides, you can certainly, it looks like there is a difference. The green is a superimposed computerized image to try for us to quantitate this. And we see a trend that the birinapant does reduce, it seems to reduce INOS. Whether this is an artifact, whether this is a direct effect of Biri affecting macrophages, or whether this is, again, with reduction in the TNF, we're seeing less macrophage activation. So the other question then, would varying regimens of birinapant and varying scheduling affect dose? Now, I did a number of different experiments, which I won't go into, but you're looking at fortnightly dosing versus higher doses versus addition of GM-CSF to see whether increasing numbers will help. But really, the most significant difference that we saw, and the increased difference, was in this regimen that I've labelled as a big hit and wait approach. But essentially, I gave birinapant 3 times a week at high dose to mice, rested them for a couple of weeks, and then repeated the treatment again. And what I saw was that there was a tenfold reduction in the burden in bacterial burden, with a significant reduction also in spleen. There was a trend to reduce monocyte count with this as well. Looking at H&E slides, you could see that there was a difference in the amount of infiltration with lymphocytic infiltration and cellular infiltration. These tend to be a bit more focal compared to the yeast process, which is a lot more diffuse. And a suggestion that, again, the iNOS within these areas seems to be a lot more, whereas it tends to be a lot more diffuse in the weekly compared to the 3-weekly. So moving on from this, I wanted to try and dissect the role of IAPs when it comes to infection with tuberculosis. I took some ex-IAP knockout mice and infected them, looked at an early time point to start with, at week 4, and found really there was no significant difference in lung and spleen. Looked at a later time point, 12 weeks, and again found no significant difference. And the mice remained relatively quite happy and well. There was no difference at all in weight loss either. So I don't think XIAP is likely to play a role in the acute mouse model. And I showed you already that its expression in an in vitro model is really is not much affected either. With regards to CIP2, I took mice and infected them. It took them by about week 8, and again I found no statistical difference between the two groups. Saw no difference in cytokines either. Even at later time points, again leaving them for longer, no difference in burden or cytokine levels. And again, there was no change in weight, and they were relatively quite happy mice. Now, in terms of the CIP1s, they surprised me a little. I expected, just like a number of other knockouts that we've had come through, that they were fine with tuberculosis. Yet these mice actually started to lose weight, and I had to take them earlier than what I intended. And you could see there was a significant increase in their weight loss. And at that point, I thought, well, perhaps maybe they were getting overwhelming infection. But in fact, I found the reverse in that they had a significant reduction in bacterial burden, and most of what I've seen so far is that this generally is we tend to see a reduction in TNF, but in this group of mice, I saw a reciprocal increase in TNF. And looking at histology, again, I'm waiting to breed more of these mice, but looking at their histology, there's potentially a slightly increased cellular infiltration. The question is whether this is what's driving the high TNF and the potentially high TNF that's driving reduction in burden, or conversely, it might be that knocking at this is actually driving non-canonical increase in TNF, which is thus reducing bacterial burden. And so, in summarising, I hope to have shown you that CIP1 and 2 expression is increased in infected TB infected system. Birinapant does have efficacy in aerosolized mouse model of TB, resulting in reduced bacterial burden. However, perhaps reduced TNF might be a hindrance, and it might be that birinapant might be shooting itself in the foot, and this reduction, and it may be a matter of just getting the right dosage, the right schedule. CIP1 deficiency seems to improve burden. This potentially also fits with this. However, there's an increase in TNF. We don't have a dual CIP1 and 2 knockout due to lethality, but what I'm hoping to do is give birinapant to these mice to see whether knocking out the CIP2 component might contribute. And I think, based on this big heat and weight approach, it would suggest that maybe targeting both CIP1 and 2 is the more effective way of going about it, given that through weeks we're providing more opportunities to knock out CIP2s, but then allowing time for macrophage recovery might be important as well. And so, looking at the cell death picture with tuberculosis, I think MCL1, other groups have shown increased expression, and we've shown in an in vivo model now that MCL1 is potentially important. Obviously, would like to clarify this a little bit more, but it would suggest that there is potential granuloma formation when you knock MCL1 out, resulting in improved control with reduction. We saw that with reduction in splenic burden in these mice. And in terms of here, it's still, I'm still working it out, but CIP1 and 2 probably both are important. And while Burinapant, is probably not something that's likely to be, moved on to clinical setting in this setting, this project I think is novel in that we've shown that it may not always be about targeting the mycobacteria, but that perhaps targeting the host and the immune system might be a potential way to go in help treating this difficult condition as well. So that concludes my talk. But I just wanted to show you, given that most of you probably wouldn't have set foot in the PC3, but essentially this is a main corridor. In here, in the corner here, there's the viral room. There is a bacterial room. This is where we do our work. It's quite crowded in here. This is the mouse room. It used to be that this room used to be this room, but subsequently, because of the huge amount of mice that we're needing, that was swapped late last year with shutdown. This is the exposure system that we use to infect TB, and it's now undergoing a UV decontamination cycle. But this is the glass nebulizer. Put the inoculum in here, and it nebulizes, and the mice happily sit in there, breathe it in. They're in there for about an hour and a half, and then they're fine. Thanks to Michael for modelling our suit that we wear when we do high-risk work. And this is the autoclave room. Every time we do TB work, we've got to autoclave out our waste. So it's quite an involved, lengthy process. So that just leaves me to thank a number of people. My PhD is no way could have been at all possible without these people. Mark, I want to thank you for your generosity of time, of ideas, of support. It's been a tremendous supervisor. Everybody in the lab has been absolutely wonderful, but in particular, I want to thank Michael. He's been my PC3 buddy from very, very early days. We worked together to get this going. Cody, Phil, and myself for providing me with all the macrophages. Greg for president with Biri in the hepatitis B stuff. Mel for all her work with supplying and making sure supplies in the PC3 are kept, helping with autoclaving and everything, all the little jobs that she's helped with. Liana for clipping hundreds and hundreds of mice. Simon for his help with flow and sorting. I'd like to thank everybody in the Infection Immunity Division. They've been great friends and great support, but in particular Joan for organisation. It's just a great support. You just run to Jo, who knows exactly what to do. Collaborators up in the University of Queensland, Nick West, who really taught me what I know with regards to the tuberculosis model and setting it up. My PhD committee, in particular James for providing us with the BCL-XL mice. Sarah, without his help and organisation of the PC3, none of the work in the PC3 would have been possible. Wendy, for her help in pushing through things, SOPs, all of those stuff that needed to be done from the get-go. Everyone else in bioservices, and Carolina having taken over Liana's job. Kerry and Ellen for all their help with all the histology aspect of things. The imaging, in particular, Mark for his help with some IF stuff that I've done, but Lockie in particular for his help with what you guys saw in terms of quantitating the immunohistochemistry. Kate for help with the cell death aspect of things and her advice. A number of people in cell imaging, in particular, Marco, John Silk, Andreas, and David both for providing me with various mice. Everyone else for reagents and antibodies and a number of different things. Security. A lot of this work was done after hours, and without them, someone else would have meant to have to stay behind in the lab to be buddies. People in media for autoclaving bottles and bottles of agar for us so we can plate our agar plates. Tetralogic for providing us with the drug. Least but not lastly, I'd like to thank God, my family, my friends whose support has been tremendous and immense, and really without their support, I probably would have given up year one. And of course, the mice. So I'd just like to take some questions now if anyone has any, and I apologise. My hearing's not the greatest with this cold either, so yes.
Davo.
Do you think birinapant will help the conventional antibiotics, or the conventional antibiotics might help birinapant?
Yeah, so I've tried that. So I've given conventional antibiotics with the help of birinapant. I didn't really see any difference, but what I did do was stop the treatment, then induce sort of what we call sort of reactivation. And what I found was that the birinapant had slightly less burden after the bacteria came back, but yeah, it didn't really that difference really didn't get any better. Yeah. Justin.
I'm thinking about the varying conditions that you've done. I mean, you've done so many exhaustively there. Amazing amount of work. Does multiplicity of infection alter things? I'm sorry if you presented that and I missed it, but
yeah.
It seemed to me that, obviously given such a high level of bacterial load, if you have a lower one to start with, does birinapant or any of the other compounds you've used have?
Mm-hmm. Okay. I can address that in two aspects. One, in the in vitro work, we know it makes a difference. Cells die with higher MOIs. People have looked into this and looked to see what type of cell death. People have looked to, it's not necrosis, it's not apoptosis, it's a different type of, cell death. So we know high MOIs induce death, but we're taking a system that's already, macrophages are activated, etc. So it's an inherently flawed system. In the in vivo setting, regardless really of what we give the mice, and I've done infections where they've received 100 at day one, at CFU of 100 at day one compared to 700, sometimes even 1,000. They always seem to control it by day 8, and they get to a baseline of about 1 by 10 to the 6. So in an in vivo model, it doesn't seem to make that much of a difference. Yeah. In the latent work, I aim to give them a little bit less. And again, I haven't seen much of a difference there.
Yeah, I know it hasn't been your main focus, but have you had a look at necroptosis at all? With MLK or knockouts? Or...
Yeah, we have, and that's the basis of Michael's project. So I won't go into that. But yeah, there's hopefully a paper coming out very, very soon. Mm.
So your theory then is that birinapant is killing infected macrophages, but then it's sort of shooting itself in the foot because you're getting rid of the macrophages which are required to gobble up more bacteria. So you're currently trying to cycle to see whether you can give a big hit, kill the macrophages, let them come back. Is there any other mechanism whereby you can try and recruit more macrophages or get more macrophages in during that sort of off period?
Yeah, so I guess one obvious way is by giving them GM-CSF, and unfortunately, GM-CSF does help in various time points. So earlier time points, there seemed to be potentially a difference with birinapant working a little bit more effectively, but subsequently that effect is lost. So I don't think that's really helped. In terms of other ways we're looking to see, the data with the CIP, with the knockout, would suggest that perhaps maybe inhibiting slightly, maybe that might alter the TNF levels. Would it drive at TNF via non-canonical sort of pathways? So I am looking at at the moment working through one where I'm giving little biri, high biris, and high biri, and looking to see whether I am seeing difference in TNF levels in the lung, to see whether we can somehow promote TNF using various doses of biri as well.
Using GM-CSF, many years ago it was found that if you give GM-CSF plus chemotactic agents, you activate ROS enormously in the macrophages. Have you tried to synergize GM-CSF's activity?
In terms of with chemotactic agents?
Yeah, to reduce ROS and killing.
No, haven't looked at that, but might be worthwhile.
Yeah, Matthew Vardis, I think, published quite a bit on that. There's a little bit of other stuff as well. But, Leishmania, if you get too many macrophages, you get worse infections, even though you're killing per macrophage more Leishmania. If you have too many macrophages, you get worse infections.
Yeah. It's sort of, it becomes that double-edged sword in that the macrophage is so central to clearing the infection. Yeah. So, which is where is very likely to progress in the setting of tuberculosis or other intracellular organisms. I think that's it's probably not. Yeah.
There's no more questions, and please join me in thanking Samar for her great presentation.